We're moving into our last topic of the afternoon. So if I can ask Dr. Harrison to come up to the microphone and get started on the smallpox vaccine use in laboratory personnel. I'll just make a mention too that we'll plan to, we have one person signed up for public comment this afternoon, so we will go along with that as well. Dr. Harrison?
Thank you and good afternoon. So I wanted to give you a little introduction about the vote that we're about to take. There are numerous occurrences of lab-acquired vaccine infection that have been reported. The current smallpox vaccine provides cross-protection against all of the orthopoxviruses, and smallpox vaccine has historically been used to protect healthcare workers and research laboratory workers against these viruses. So you've seen some of these pictures. I just want to remind you what laboratory-acquired vaccinia looks like. So this is an ocular case who was treated with a VIG and had full recovery. This is a needle stick case, as I recall, from Brazil. And you can see the evolution of the lesion over time. And this is another laboratory-acquired infection involving the left eye and the right ear. So actually, one of the working group members asked that I add a few slides on complications of smallpox vaccination. And so I added this one. This is a fatal case in a child with immunodeficiency. And we also have a case of a woman with CLL with progressive vaccinia and a man with eczema vaccinatum. This is a man who had a history of atopic dermatitis. He survived with therapy, but he was left with scars. I should point out that these complications generally do not occur with the screening that currently goes on for contraindications before immunization. So this is a slide from Mary Reynolds. This is actually a discussion of this is in one of the papers that was in your background information. So talking about the basically vaccination versus laboratory infection. So with vaccination, you get a well-formulated virus in a dosage delivered in the place where you want it to go. In terms of laboratory infection, you have a variety of different strains that are out there being used by a variety of different laboratories. You can get a high concentration of virus, and it may be through an unusual route, deeper injection, and other body sites, including the eye. So ACIP made recommendations in 2003 for smallpox vaccination of laboratory workers. There's a new smallpox vaccine since then, ACAM 2000, which was licensed in 2000, and which basically put Dryvax into retirement. So the working group was established in March of 2013, and we have generally, not always, but generally had monthly meetings since that time. So I want to thank all of the working group members, including Brett Peterson, who will be talking next, the CDC lead. And we really got a lot of great input from members of the working group. It was a very productive group, led to very good discussions and a very detailed working through of a lot of the issues that were before us. So just a reminder, I'm going to go through this very quickly. You've seen this probably about 3 times before. And so we reviewed recommendations from 2001 and 2003. We reviewed other documents, including case reports of exposures and cases. We reviewed data on the new vaccine, ACAM 2000, including safety and immunogenicity, and adverse events with the current very stringent pre-screening program. And we also looked at some data historically from Dryvax. Now, we did briefly touch on Imvamune. Imvamune is based on modified Vaccinia ankara, which is not competent to replicate in mammalian cells, but it is, as best I can tell, its licensure is not imminent. And so we really weren't making any recommendations about this unlicensed vaccine, but I anticipate that this will occur in the future. So, and we reviewed data on recombinant vaccinia viruses in development or under investigation in clinical trials to provide the guidance that we're about to talk about. And so the final product of this discussion is going to be a single ACIP policy note for publication. So with that, I will stop and hand it over to Brett.
Okay, thank you, Dr. Harrison. And thanks to everybody for sticking around. I'm sure this has been a long day for everyone here. But today we're going to talk about the use of smallpox vaccine in laboratory and healthcare workers at risk for occupational exposure to orthopoxviruses. So I'll start with just a brief background before summarizing the grade process and evidence that the working group reviewed before finishing with a presentation of the proposed revised recommendations. So orthopoxviruses are a group of large double-stranded DNA viruses within the family Poxviridae. There are 4 known species that infect humans, including variola or smallpox. Vaccinia is the smallpox vaccine, monkeypox, and cowpox. Orthopoxvirus infections do provide cross-protection across species, as Dr. Harrison mentioned, and it's this property that allowed the development of vaccinia as a vaccine for smallpox and ultimately resulted in the eradication of smallpox as a human disease. However, orthopoxviruses do remain an active subject of research, and in particular, vaccinia viruses are commonly used in laboratory research. So there are many historic vaccine seed stocks and derivatives of vaccinia virus, some of which are listed here, and each of the different strains has varying degrees of attenuation and safety profiles. Recombinant vaccinia viruses are also being used increasingly in the laboratory as viral vectors for expression of foreign genes, recombinant vaccines, as well as even oncolytic and immunotherapies for cancer. So vaccinia virus smallpox vaccines have been recommended by the ACIP for the protection of laboratory workers against orthopoxvirus diseases since 1980. The last time the recommendations were revised for a laboratory worker was in 2001, at which time vaccinia vaccine was recommended for laboratory workers who directly handle cultures or animals contaminated or infected with non-highly attenuated vaccinia virus, recombinant vaccinia viruses derived from non-highly attenuated vaccinia strains, or other orthopoxviruses that infects humans. It was also recommended that vaccination be offered to healthcare workers who have direct contact with dressings or other infectious materials from volunteers in clinical studies where non-highly attenuated vaccinia viruses or recombinant viruses derived from these strains are used. Furthermore, laboratory and healthcare personnel working with highly attenuated poxvirus strains were not recommended to receive routine vaccinia vaccination. And the highly attenuated poxvirus strains referred to are listed here. In terms of a brief smallpox vaccine overview, ACAM 2000, as Dr. Harrison mentioned, is currently the only smallpox vaccine licensed and available in the United States. It was licensed in 2007 and replaced the previously used smallpox vaccine Dryvax, which was the vaccine referred to in the previous ACIP recommendations. And as Dr. Harrison mentioned, this vaccine is no longer available. Since that time, ACAM 2000 has been used in laboratory and healthcare workers as well as select Department of Defense personnel. ACAM 2000 is a live vaccinia virus vaccine. It's produced in vero cells under good manufacturing practices. It's derived from a clonal isolate of Dryvax, which was a New York City Board of Health strain that was used during the smallpox eradication campaign. The vaccine is administered percutaneously via multiple puncture with a bifurcated needle, which is pictured here. Following vaccine administration, a lesion develops at the site of vaccination. This image shows the progression of a vaccination lesion. And these vaccination site lesions do contain infectious virus that can be transmitted to others as well as to other parts of the body, as we saw previously in those cases of autoinoculation that Dr. Harrison showed. However, this vaccination lesion is also called a cutaneous response or a take, and it is considered a marker of successful vaccination. Historically, smallpox vaccines have been associated with a number of adverse events, and some of them can be severe and life-threatening, including eczema vaccinatum and progressive vaccinia, which we saw examples of in Dr. Harrison's introduction, as well as post-vaccinal encephalitis. And so this table presents the rate of adverse events from following primary vaccination with Dryvax that were detected during a study performed in 1968, at which time smallpox vaccination was part of the routine childhood immunizations. This table shows the rate of adverse events following revaccination with Dryvax, and this is from the same 1968 study. And overall, you can see that the rates of adverse events following revaccination are substantially lower than those following primary vaccination. A more recent study evaluated the adverse event rates observed during the Department of Defense and Department of Health and Human Services smallpox vaccination program in 2002 to 2005. And those rates are shown here in this table. The first point of note is the absence of eczema vaccinatum and progressive vaccinia, which might be attributable to the stringent screening that participants underwent for contraindications. But I should point out that there have been single cases of each of these adverse events since this study was completed associated with smallpox vaccination under the Department of Defense vaccine program. The second point of note from this study was the identification of myopericarditis, which had not been previously recognized as a common adverse event associated with smallpox vaccine. So using this background, our working group used the grade methodology to develop a policy question, identify and assess the outcomes of interest, conduct a literature review, summarize the evidence for critical outcomes, and evaluate the quality of evidence for those outcomes. The policy question formulated by the working group was, should administration of ACAM2000 be recommended routinely to persons at risk for occupational exposure to orthopoxviruses? The population of interest was defined as persons at risk for exposure to orthopoxviruses. The intervention was vaccination with ACAM2000, and the comparison was vaccination with Dryvax. The working group used the modified Delphi analysis to solicit outcome assessments from working group members regarding outcomes of interest. The benefit outcomes identified included vaccine efficacy to prevent orthopoxviral disease, cutaneous response, and the neutralizing antibody response. The harms outcomes identified were serious adverse events, myopericarditis resolved with sequelae, and myopericarditis resolved without sequelae, inadvertent inoculation, and mild adverse events. All of the outcomes were assessed to be important, and all were eventually included in the final evidence profile. A systematic literature review was conducted and identified 5 randomized controlled trials that met the criteria of the policy question and addressed the outcomes of interest identified by the working group. The following slides provide a brief summary of the critical outcomes evaluated. The cutaneous response was best assessed in 2 studies evaluating this outcome in vaccinia-naive as well as previously vaccinated subjects who received ACAM2000 or Dryvax, which was used as a comparator. And these studies found that ACAM2000 was non-inferior to Dryvax in producing a cutaneous response in the vaccinia-naive population, but not in the previously vaccinated population. These studies also evaluated the neutralizing antibody response and found that ACAM2000 was non-inferior to Dryvax in producing a neutralizing antibody response in previously vaccinated subjects, but not in vaccinia-naive subjects. And so there certainly was a robust neutralizing antibody response in the vaccinia-naive subjects, but it was but it was not found to be non-inferior to the response seen in dry vax recipients. In summarizing the critical harms outcomes, in terms of serious adverse events, there were no incidents of death, eczema vaccinatum, progressive vaccinia, or post-vaccinal encephalitis that were reported in any of the clinical trial participants. Again, possibly secondary to the intense screening that the clinical trial participants underwent. With respect to myopericarditis, this adverse event was observed in recipients of both ACAMP 2000 as well as DryVax, though there was no significant difference between the rates among these two groups. With respect to ACAMP 2000, 5.7 cases per 1,000 vaccinees was thought to be the best evidence of risk for myopericarditis based on the phase 3 clinical trial results. And 2 cases of myopericarditis were identified to have sequelae, that being persistent abnormal echocardiograms, although all cases of myopericarditis in these clinical trials did resolve. So we used the grade methodology to evaluate the quality of evidence, which is summarized in this table. There were no concerns for risk of bias or inconsistency identified in any of the trials. However, indirectness and imprecision were identified as issues for several outcomes, and the evidence type was downgraded accordingly. And I'll talk about these biases in the following slides. With respect to indirectness, 3 outcomes were downgraded for indirectness because the outcome that was assessed was likely different from that of primary interest. So for cutaneous response and neutralizing antibody response, these were used as surrogates for the outcome of primary interest, which was vaccine efficacy to prevent orthopoxviral disease. There was no data available for this primary outcome. With respect to myopericarditis, the clinical significance of myopericarditis that resolved without sequelae was really unclear, and many of these cases were actually asymptomatic disease that were only detected due to the intensive cardiac monitoring that the participants underwent, including routine EKG and cardiac enzyme evaluations. And so for this reason, the myopericarditis resolved with sequelae was thought to be more likely clinically relevant, and this was assessed to be the outcome of primary interest. The serious adverse events and inadvertent inoculation outcomes were downgraded for imprecision, as the clinical trials were not adequately powered to detect either of these adverse events. And we've included a number of the calculations that we performed that really illustrate this fact in the table. So based on our grade assessment, the overall level of evidence was determined to be a level 2, which is consistent with randomized clinical trials with important limitations. The working group did also consider the risk of exposure and infection in developing the proposed recommendations, and found that these risks are actually very difficult to quantify. So the populations at risk for orthopoxviral disease is not known and is difficult to estimate, as there is no registry of persons who work with orthopoxviruses. However, the working group did look at a number of indirect measures which give some sense of the size of this population, including the number of orthopoxvirus-related publications, number of NIH projects and clinical trials listed on websites, as well as the amount of smallpox vaccine that was distributed for use among laboratory workers. Specifically addressing the risk of orthopoxviral disease, this is also very difficult to estimate in persons who are working with these viruses, as vaccinia and cowpox infections are not reportable conditions, so surveillance is not robust, and the true burden of disease in this population is not well known. Additionally, the orthopoxvirus exposures are certainly not always reported, and particularly when there's no resulting infection, it's less likely to be reported. And lastly, as Dr. Harrison also noted, the pathogenicity and virulence of the virus may not be well characterized, particularly with respect to the recombinant viruses, where virulence may be either attenuated or enhanced. However, CDC does maintain a database of lab-related orthopoxvirus exposures and infections, and this slide summarizes the reports to CDC during the time period of 2004 to 2014. And during that time, there were 26 exposure incidents reported. 69% of these involved recombinant viruses. More than half of these exposures did result in infections, and among the infections, 86% involved recombinant viruses. An additional 86% were vaccinia infections, whereas 2 were cowpox infections. 29% of the infections reported required hospitalization, and another 29% of the infections reported actually involved a strain other than that which the laboratorian thought that they were working with. 27% of the exposures met the ACIP vaccination recommendations, but one of the 7 who did meet the ACIP recommendations did result in infection. There was one other infection that had occurred in an individual who had been vaccinated greater than 10 years prior, and so was not in accord with the ACIP recommendations for revaccination. So in summary, the working group concluded that ACAM 2000 is comparable to Dryvax in providing protection against orthopoxviruses. The overall evidence type was found to be a level 2. And after considering the risk for infection, the risk for adverse events, as well as the benefits from vaccination, the work group proposes extending the current ACIP recommendations for use of smallpox vaccine among laboratory and healthcare workers at risk for occupational exposure to orthopoxviruses. The language for these key recommendations are contained in the following slides. The working group proposes that routine vaccination with ACAM 2000 is recommended for laboratory workers who directly handle A, cultures, or B, animals contaminated or infected with replication-competent vaccinia virus, recombinant vaccinia viruses derived from replication-competent vaccinia strains, or other orthopoxviruses that infect humans, for example, monkeypox, cowpox, and variola. The working group proposes recommendation category A for this and evidence type level 2. I'll note that this recommendation is essentially the same as the previous 2001 recommendation, with the exception that replication competent is used in place of non-highly attenuated, and this was a recommendation put forward by the working group to increase the clarity and specificity of the recommendations. Working group also proposes that vaccination with ACAM 2000 is not recommended for persons who work only with replication-deficient strains of vaccinia virus, for example, MVA, NIVAC, TROVAC, and ALVAC. This was also recommendation category A, with the evidence type level 2. And this recommendation is also the same language that was contained in the 2001 recommendation, with the exception of the changed language for replication deficient as opposed to highly attenuated vaccinia strains. Working group also proposes that healthcare workers, for example, physicians and nurses, whose contact with replication-competent vaccinia viruses is limited to contaminated materials, for example, dressings, and persons administering ACAM 2000 smallpox vaccine who adhere to appropriate infection prevention measures be offered vaccination with ACAM 2000. This was suggested as a recommendation category B, given the limited data to support this recommendation, but also with the evidence type level 2. Lastly, with respect to contraindications, the working group proposes that the previous contraindications for smallpox vaccination in this population remain in place, but also recommended that a contraindication for persons with a household contact less than 1 year of age be added, given that this population is at increased risk of severe adverse events. The working group also proposes the removal of the contraindication for revaccinations of persons who have 3 or more known major cardiac risk factors, given that myopericarditis was not seen in clinical trial participants who were undergoing revaccination and was only seen in primary vaccinees. I will note that the working group was not unanimous in support of these proposed recommendations, and one working group member submitted the following 2 slides for your consideration. They point out that the majority of lab workers who are currently being vaccinated are likely receiving a primary vaccination, since routine smallpox vaccination was discontinued in 1971. So lab workers today may therefore be at increased risk of adverse events compared to laboratory workers in 1980 when this recommendation was first put in place. Because in 1980, many of those laboratory workers were likely being revaccinated. This slide also points out that smallpox and monkeypox generally cause more severe disease when compared to vaccinia, as well as cowpox, and argue that these factors should be considered in the ultimate risk-benefit analysis. This working group member did offer some alternative language in recommending vaccination for persons who are working with vaccinia virus specifically, and suggested a lower level of recommendation be considered for this, this population. But I will lastly note that there did seem to be general consensus among the working group for a Category A recommendation for persons working with vaccinia virus to be vaccinated with ACAM 2000. And after the multiple reviews of the language and the policy note recommendations, I did not receive any individual input from other working group members that suggested that this should be other than a Category A recommendation. So that essentially concludes my talk. Next steps, obviously, questions and discussion before vote. And so I will just close by thanking again, along with Dr. Harrison, all of the members of the working group member for the excellent input and discussions that went into these proposed recommendations. And with that, I will open the floor to questions. Thank you.
Thank you, Dr. Peterson and Dr. Harrison. I see a number of hands up. Dr. Bologna, Dr. Campos-Outacalde, Dr. Karen, and I need to check here. Okay. So, Dr. Bologna.
Thank you. Can you tell us a little bit more about current DoD policy and recent DoD experience with the use of ACAM 2000?
Sure. So in general, I would say that the Department of Defense recommendations are essentially in line with ACIP recommendations. Their contraindications are essentially equivalent, I would say, to what's contained in the ACIP, with some of the proposed changes to contraindications that we've included in our revised recommendations. Those would be the exceptions, I think, to the consistency with DoD recommendations. But that would be my general answer.
Any more recent safety data from DoD? You showed data prior to 2005.
In terms of safety data, we did have a presentation from the Department of Defense, and I don't think there were any new safety signals that were identified in the ongoing Department of Defense smallpox vaccination program. So certainly nothing, I think, out of the ordinary or unexpected.
Dr. Campos-Outacalde.
Yeah, I have 2 questions. The first one, I want to just follow up on this Department of Defense question. How many members of the Department of Defense are now being vaccinated?
Mm-hmm. Well, the Department of Defense is still vaccinating certain individuals who are being deployed, is my understanding. It's a small number. I don't know the exact numbers, but it is a small number of their force.
Eric Sherjanko, DoD liaison to the CDC. We are still vaccinating, going in areas where there's a concern for potential terrorist of a small number. It was larger when we were in Afghanistan, where most as was mentioned by Brett, safety profile really hasn't that number of folks getting back.
Thank you.
Second question. That one came up kind of quick. Okay, so I want to look at slide 26 and the first bullet, which basically says ACAM 2000 is comparable to Dryvax in providing protection for Orthopoxvirus. Overall level of evidence too. Then I want to go back and look at slides 16 and 17 and tell me how you get that bullet from looking at slides 16 and 17.
Sure. So clearly what we would be most interested in knowing is how well ACAM 2000 protects against orthopoxviral disease. Now, currently there is not a lot of naturally occurring orthopoxviral disease in the world. Since the eradication of smallpox, those orthopoxvirus infections occur rarely. And so to actually show efficacy for ACAM 2000 in a natural orthopoxvirus infection would be very difficult to do. And so these are clearly surrogates for that outcome, which is of primary interest. And so cutaneous response has been demonstrated during the smallpox eradication era as a marker of vaccination success. And so historically, smallpox vaccines were not studied rigorously. There were no clinical trials to prove their efficacy, but their effectiveness was ultimately demonstrated by the eradication of disease. So while we recognize that these outcomes are surrogate outcomes, the working group did feel that this was significant evidence for protection against orthopoxviral disease.
Okay, but that's different than what you say in bullet 1. You say it's comparable to Dryvax, and I don't think your slides 16 and 17 show that to be true. In each instance, you have inferiority to Dryvax in one of the two groups.
Mm-hmm.
So I'm okay with saying you believe it's effective in preventing orthopoxvirus. I don't think you're accurate in saying it's comparable to Dryvax based on what you've shown us.
Sure. Certainly comparable is a subjective assessment. And there were differences that we've demonstrated in this data comparing ACAM 2000 and Dryvax. The arguments to downplay the differences would be that the differences between vaccinated and naive and previously vaccinated subjects for ACAM 2000, in terms of the cutaneous response, we know that the cutaneous response can be affected by previous vaccination. So the fact that there are differences in previously vaccinated subjects may be related to that fact, although the numbers are certainly different. Trying to move on to the antibody response. There we go. And so with respect to the neutralizing antibody response, ACAM 2000 did not meet inferiority to Dryvax, but there was a robust neutralizing antibody response seen. We don't know what the level of antibody response is required to provide protection, and it was very close to meeting non-inferiority. So those would be the rebuttal arguments.
I just have to repeat my comment, which is I think you can say you believe and Dryvax isn't an issue anymore. It's not like we're making a choice between one vaccine or the other. So from what you've shown us, it's not, when you say comparable, I suppose that's enough wiggle room to say equivalent. It's not equivalent.
Yep.
But when you're using surrogate markers, so that's what we all recognize that we don't know exactly what they mean, but they weren't the same results.
Yep.
Okay, so
yeah, I certainly agree with you, and reasonable people can certainly have differences of opinion in terms of language and subjective evaluations.
Dr. Karen.
Yes, I was wondering about the exposure incidence, the laboratory incidence, and the fact that only 7 individuals would have met criteria for vaccination. Was that because the other 19 individuals were working in laboratories, or facilities, but not working directly with the virus? Or who were those other 19 and why did they not?
Perhaps I need to clarify that the other individuals were not vaccinated at all. I think that's the answer to your question. So, excuse me, so 7 met ACIP vaccination recommendations, and only one of those actually came down with the disease. So the others were exposed, but they were vaccinated according to ACIP recommendations, and they did not develop orthopoxvirus infection.
Can you just clarify if the word you mean by met ACIP vaccination recommendations that they had gotten the recommended vaccine?
Correct.
But all of these
That they
people
had been
all of these
vaccinated.
people, right, I think Ruth's question was, were all of these people in a group that would have been recommended to get vaccine? Were they that kind of lab work?
Yes, yes.
We have Dr. Weber.
Yes, thank you. I represent Shay. Also, I should say, being at the University of North Carolina, where we have a large defense group, I've personally taken care of at least 2 cases from DOD, one with one with post-vaccinal encephalitis and contact with generalized vaccinia, as well as several soldiers who had recent inoculations, still had dressings, and were at our hospital for other reasons. First, just a general comment. Could you please change the word worker to personnel, since we'd certainly, I assume graduate students are going to be working on this as well, and they're not necessarily workers, so make it more inclusive to include students and trainees. But then, turning towards your recommendations for healthcare personnel, I find that much too ambiguous. Really doesn't provide the precision we need. It doesn't describe who makes the decision to immunize them. Is it the facility? And keep in mind, we need to get vaccine from the health department or the local health department. Is it going to be used pre-exposure? So should my hospital have a group of people who've had immunization? Is it going to be used at the time of taking care of a person with a complication of vaccinia? Is it going to be used post-exposure? It doesn't say anything about boosters, so are those people just immunized once, or should they be up to date within 10 years on a booster? So I'd encourage you to make that recommendation much more precise to give the hospital epidemiologist some guidance as to when vaccine immunization of healthcare personnel is indicated. Thank you.
Sure, we can certainly work with you to try to make this language more precise, but in terms of revaccination, that is included, but has not changed from previous recommendations, so didn't make it a point to discuss that. With regards to how the vaccine would be used, this is a very specific document targeting a very specific population, so persons occupationally exposed to orthopoxviruses. It does not involve persons who may be vaccinated for other reasons. Certainly DOD makes their own decisions about smallpox vaccination, and it does not address the potential first responder population. So we tried to make it as focused as we could on specifically the laboratory personnel population.
Then exactly what healthcare personnel are you talking about? Are you talking about people doing research, or are you talking about people who would be at a healthcare facility providing care to some of these people who have developed a complication of vaccinia?
Mm-hmm. So we are addressing both of those populations. The laboratory personnel under these proposed recommendations would be recommended to receive smallpox vaccination. The healthcare workers, as we describe them in the language here, those who have contact with replication-competent vaccinia viruses, which is limited to contaminated materials, and persons administering ACAM 2000 smallpox vaccine who adhere to appropriate infection prevention measures could be offered vaccination with ACAM 2000. So this is a little bit more of a lenient vaccination can be offered rather than recommendation, and for that reason, it's a category B recommendation.
My only argument is it's just not providing enough precision to a hospital epidemiologist to know who they should offer them and under what circumstances that it should actually be offered there, and who makes the decision, whether it's going to be the hospital that makes the decision or the local county state health department.
Okay.
I'm going to go to Dr. Decker, Dr. Romero, Dr. Bennett, Dr. Plotkin, Dr. Kemp, and I see Dr. Moore.
So just to offer some additional information to the committee, since the time of original licensure of ACAM 2000, there's been a family of post-marketing safety studies underway. Most of them, some have finished, most still continue. The data that can be provided from those at this point prior to final analysis was provided to CDC last year and will not have materially changed. In total, there's been nearly 1 million DoD personnel vaccinated who have come under surveillance in one or more of these studies. And so the information that's available to be pretty robust. The safety data set is not likely to increase further in coming years because of things like the cessation of deployments to the Middle East and other factors that will mean that we're not going to be seeing DoD-based vaccinations occurring at the rate that they have in the past. And those vaccinations represent, 99.9% of all vaccinations that have occurred in the country.
Thank you. Dr. Romero.
Returning to this slide, and several questions. So first of all, what's the policy of the DoD with regard to their and nurses either administer this vaccine or care for the individuals that get the vaccine? Does anybody know what? Anybody answer?
The question was, is what does DoD do for the providers that are taking care of people who are getting vaccinated?
Yeah,
So part of their force health protection is they get vaccinated as well.
They are vaccinated as well, right? Right. That's what I understand. So, so part of the problem is that I'm old enough to have gotten the vaccine as a child. I'm also old enough to have been a vaccinator during the last round of vaccination. And so all of us that were vaccinators were vaccinated before we began to give the vaccine. And so I wonder why this is a Category B recommendation instead of just taking it up to Category A, because those individuals are exposed to the vaccine. And in my other hat in another institution was on the Biosafety Committee. And so we've had this question of, well, how do we administer it at an institution where we don't have somebody who's been vaccinated? How do we bring it in? How do we give it? So I think that you have to sort of address that issue and, as was stated previously, give more firm recommendations about how to use it.
Okay, fair enough. I think the Category B recommendation specifically for vaccinators was just simply because it hasn't been studied robustly. We're certainly not aware of any infections that have resulted from exposures during vaccination in vaccinators, but without a strong data base to support that, it was felt to be a Category B recommendation. But I certainly wouldn't be opposed to making that a Category A recommendation.
Dr. Shukat.
Dr. Damon has a...
So I think historically in the 2002 vaccination program, part of the decision to vaccinate the vaccinators was made because it was assumed that the vaccinators would also be part of the response. Whereas in this case, these are individuals who are simply taking care of patients on study or taking care of individuals vaccinated.
I'll also point out that the volume of vaccine being administered by this specific vaccinating population is likely to be much lower, given that there aren't a whole lot of laboratory workers who are administering vaccine. So their cumulative risk of being exposed while vaccinating may be lower than in other larger smallpox vaccination programs.
Dr. Bennett?
Just one quick question about the myocarditis. The new recommendations are not to expose someone who has more, 3 or more known cardiac risk factors. Can you talk a little bit about the relationship between known cardiac risk factors and the myocarditis? My understanding of myocarditis is it can happen to anybody.
Yes, that's correct. And this was one of actually the more difficult issues that the working group dealt with. And so you're correct that with myopericarditis, there aren't any known risk factors for attempting to predict who may have this adverse event. But the rationale that was used to support this recommendation is the fact that if somebody did undergo this adverse event, then they would more likely have a more severe outcome based on either known heart disease or known cardiac risk factors. And so that's why ultimately this recommendation was proposed by the working group.
Dr. Plotkin?
Yes, I just wanted to answer Dr. Campus' question. Perhaps I'm the only one old enough to remember this, but the mechanistic correlate of protection for smallpox vaccine is antibody. Antibody lasts, as a matter of fact, as long as 70 years and remains protective, at least partially protective during that time. And the level of antibody that is protective has been estimated to be 1 to 32. So the geometric mean of the ACAMVS is well above that. However, it might be more useful to give a percentage of those who had titers of 1 to 32 or greater. Also, I take it there are no data on the cellular response, which is important in closing off the vaccinia replication. But since the ACAMVS vaccinees apparently did that, that implies that they did develop a cellular response. So I think the ACAMVS may not have the same level of antibody response, but as long as the level persists, it should be just as effective as Dryvax.
Thank you much. Dr. Kemp.
I was just wondering if you could comment at all on the issue of whether vaccinia, in fact, the outcomes when you look at vaccinia virus infection are substantially less severe, and whether you're able to repeat any of these analyses based on that data. And maybe someone like Dr. Plotkin might be able to comment on whether that's really a concern or not.
Well, certainly there have been studies in the past looking at some of the historical smallpox vaccine, and it has been observed that the take or cutaneous response to vaccination is ameliorated by previous vaccination. And so this could be looked at with ACAM 2000. I don't believe it has, but that's something that we could look into. And that would be one example of a direct demonstration of ACAM 2000 protecting against orthopoxvirus infection.
And Dr. Moore.
Yes, thanks. Kelly Moore with AIM. My question was actually a practical one. How do these civilian laboratory personnel receive the vaccines? Because they can't call my office and get them here in the Tennessee immunization program. And so I have had a graduate student contact me from another state because they were beginning a project where they were working with the vaccinia virus, and they couldn't figure out how to obtain the vaccine, and I was unable to assist them. So a little bit about the practicalities, and also, are there any safeguards in place to assure that laboratory personnel who have now a Category A recommendation have adequate access to the vaccine, and that it isn't a function simply of a facility that decides on their behalf whether they're going to offer that or not? Thanks.
Great, thank you for those suggestions. We did include in the policy note updated information on how to request the vaccine. You're correct that CDC is the only source of smallpox vaccine, but it is made freely available. And explicit instructions on how to request a smallpox vaccine from CDC's drug services is included in the policy note. So there shouldn't be any barriers to receiving smallpox vaccine. What I have heard in the past is that one of the main barriers has actually been finding somebody willing to administer the vaccine with the thought that they needed to be vaccinated, and so not being able to find somebody vaccinated that would be willing to administer the vaccine. And so part of the thought in making those recommendations for vaccinators for this population more explicit is to help ameliorate the potential for barrier to vaccination from that standpoint.
So at this point, it seems like there are a number of somewhat unresolved questions out there, particularly, I think, stated by Dr. Weber from Shea in terms of identification, who should get this. Does having a laboratory in your community indicate that one of your hospitals should have personnel aboard and so on? The question I have for the committee is whether or not we want to push on with this tonight. Do we want to, I don't think there's appropriate time for the work group to meet, modify, and so on by tomorrow. So one of the questions is it something that we would feel comfortable sending back like we did with the yellow fever vote, and just have a little bit more consideration for some of these topics and bring it back to the October meeting. And in particular, Dr. Harrison, since you're the lead.
Maybe we should ask Brett if he feels he could address these issues and present. Is it an option to present briefly tomorrow a revised recommendation that addresses these issues? Brett, I don't know what your thought is about that versus.
Happy to discuss with Dr. Weber how we can clarify some of the language and identify where there might be deficiencies.
I think there's some minor points, but things that I think we would like to have a little bit. And Dr. Harrison did make the point that we would like to have things laid out pretty clearly before we make a vote. And right now there's been a lot of cross-talk, so I would propose that we come back to this first thing in the morning, I think after the agency updates, if that would be acceptable. Is that? Okay. That being the case, I'm going to just go ahead. And is Robert Benjamin still here? Okay, then we will not have his comment today, perhaps tomorrow. Any further comment? Discussion? If that's the case, one announcement, the Emory Conference Hotel shuttle is available for anyone who wants to ride on over. I'm not sure if it's raining out there or not, but other than that, I think we stand adjourned for the day, and thank everybody for your attention and getting through this.